Hello, everyone. Thank you for joining us today for our PrEP and PEP Access Innovative Solutions for Hard-to-Reach Populations webinar. We apologize for the issue that happened last week. Our webinar platform went down, but they assured us that we won't have that issue again today. So I look forward to a wonderful webinar. A little bit about UCHAPS. UCHAPS stands for the Urban Coalition for HIV/AIDS Prevention Services. The UCHAPS is a national collaboration of community partners and health departments dedicated to preventing new infections and reducing health disparities. UCHAPS seeks to bring attention and resources to areas that have faced a disproportionate burden of HIV infection throughout the history of the epidemic. I'll be your moderator today. My name is Kenya Hutton. A little bit about me: I have 17 plus years working in the LGBTQ community in areas of health, equity, and social justice, and I currently am the program manager here at UCHAPS. A few housekeeping rules. All lines will remain muted during the webinar. Please submit any questions and comments using either the chat box or the Q&A box, or feel free to email me at kenya@uchaps.org. Your chat box, if you see a taskbar similar to the one on the screen right there, right here is where you'll be able to find your Q&A box. When you hit the button, a box will pop up and you'll be able to ask your question directly to us or directly to a panelist. Or if you'd like to ask a general question to the entire audience, feel free to use the chat box right there. And when you click that button, another box will pop up. During the Q&A section, we will field your questions to the appropriate presenter and get your responses. So our presenters today are Nikay Blue, Damon Jacob, and Angela Hoff. Our first presenter is Nikay Blue. Say a little bit about Nikay Blue. Nikay Blue, MPH, is a public health professional who serves as the Chief Program Officer with AIDS Foundation Houston, the oldest AIDS service organization in Texas, established in 1982. As Chief Program Officer, Nikay spearheaded the transitioning of 3 departments into one: Housing, Prevention, and Support Services. More recently, she developed AFH's first PrEP clinic in the span of 6 weeks. She has been a member of the Houston Community Planning Group since 2007, Texas Community Planning Group since 2006, and a member of the UCHAPS since 2012. I'm about to hand the controls over to Nikay. So Nikay, when you're ready, please feel free to begin. Hi, Nikay, I'm not hearing you.
Can you hear me now? Hello?
I hear you now, Nikay.
Awesome. Thank you. Hello, everyone, and thank you for listening. Thank you, Kenya, and thank you to UCHAPS for continuing to promote the sharing of information and resources through these valuable webinars. As Kenya mentioned, AIDS Foundation Houston, we've been around since 1982. Our goal and emphasis focuses around reducing the impact of HIV/AIDS in our community. We do this through providing stabilizing services to those that are affected by HIV or AIDS through support when it comes to medical adherence, linkage to care, housing, testing, and we also have several support service programs that reach youth living with HIV and also the incarcerated and reentry populations across the state of Texas. as he mentioned, I've been with the organization for almost 15 years, and I can remember back in 2010 when the HIV field was changing when it comes to funding, and everyone was hearing the message that if you want your organization or your prevention program to survive, you must become a federally qualified health center, or FQHC, as most people call them. For us at AIDS Foundation Houston, we knew that the communities we served weren't readily able to engage in medical services. So we needed to figure out how to make the connection from community to FQHC or to a medical clinic. The reason why our community was struggling with engaging in medical services had to do with stigma, discrimination, poverty, and other social determinants of health like housing, food, and quality education. So as a result of our historical background dealing in this area and providing these types of services, we as an organization made the decision in 2012 not to broaden our scope of service, but instead work to leverage existing resources and build new partnerships. This PrEP clinic that we started in 2017 is one of those examples. And today I will share with you how you can leverage 340B cost savings to expand services and increase access for marginalized populations to PrEP through strategic partnerships. We started our PrEP clinic in December 2007 in collaboration with a private infectious disease doctor. Our priority population for our clinic was men who have sex with men of color over the age of 18 years old. We wanted to start with this group because in Houston and in Texas, men who have sex with men, I think this has timing on it. Sorry about that. Men who have sex with men in Houston and in Texas have the worst viral suppression rates at about 40% when it comes to viral suppression. So our thought was, what can we do upstream to reduce barriers to accessing PrEP and help prevent acquisition of HIV in the first place? So what is the 340B drug pricing program? Let's see. This went way up. There we go. All right, I'm figuring it out. 340B is a drug pricing program that is administered by HRSA through the Office of Pharmacy Affairs. 340B makes it possible for qualifying entities to access significant discounts on prescription drugs and offer those drugs to patients at reduced price. So all pharmaceutical manufacturers selling their drugs in Medicaid are required to participate in 340B as part of the pharmaceutical pricing agreement. This funding does not come from our federal government or our tax revenue. It comes from the pharmaceutical companies. This enables organizations like ourselves and others to expand the safety net services that we provide. And so the ultimate goal of 340B for all of us and for HRSA is to stretch the scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. 340B is something that happens in the back end that your patients and clients would not see. So they would not know whether they are a 340B client or not. What qualifies AIDS Foundation Houston for 340B is our CDC directly funded grant. through PS 15-1502. And in particular, it is the scope of service of HIV testing and integrated STD screening, which qualifies us for this. So if you're wondering whether you qualify for 340B, the first place where you should look is within your grant's scope of work. Our qualification, so if you look under the eligibility requirements that you're seeing on the screen right now, we are considered a specialized clinic, a sexually transmitted disease clinic. But there are many other types of covered entities. That includes Ryan White grantees who can receive 340B cost savings for HIV medications, cancer hospitals, and all of these different types of eligibility entities. There are also additional mechanisms for eligibility that include Section 318 sexual transmitted disease funds from CDC and 330, which is usually received by family planning clinics. So the structure of our partnership. As I mentioned earlier, we are a standalone community-based organization. The first thing we had to do to get this started was find a medical provider, but not just any medical provider, the right one. You can choose to work with a medical provider who has experience in the HIV field, or you can choose to work with a medical provider who is interested that needs training. There are many avenues in which you can get the individual or the institution trained to be able to provide PrEP for your 340B clinic. So for our purposes, we chose to select an infectious disease doctor with a private practice specializing in HIV who was already culturally competent to serve the GLBTQ community. We established an MOU, our business agreement for their services, and this is critical and a key piece of compliance when it comes to 340B. This must be in place, and that's regardless of if the medical provider provides the services in kind or for pay. And if, regardless of whether it's in kind or for pay, you are essentially bringing this provider into your work to expand your services. Another piece of the structure of the partnership that's critically important is the contract pharmacy. The selection of the right pharmacy is going to be critical to your success, especially if you're not a clinic like us. If you're not a clinic, if you've never done medical billing, and if you don't have an internal pharmacy, the right administrative pharmacy will provide all those services and more to support your program, so you as a community-based organization can stick to the core of your work, which is usually outreach, testing, education, counseling, doing those things. So for us, our administrative pharmacy, they distribute, reconcile, and maintain all of our medications. They contact the client or the patient and remind them about refills, insurance, doing all of those medical billing pieces that happen in the back end when it comes to filling prescriptions, getting them filled, and making sure the right people are paid. And last within our partnership, of course, is going to be Gilead. Gilead is currently the only pharmaceutical provider that has a drug related to PrEP, which is Truvada. Gilead provides two patient assistance programs, one for individuals with insurance, which is a copay card, and then a second for individuals without insurance, which will cover the full cost of the PrEP drug. And there are also several private foundations out there that help to pay for prescriptions when a patient's copay card or patient assistance program might have expired or used all of their funds. So who is eligible for our clinic? Anyone we test for HIV is eligible, and that is regardless of the source of funding that we may test the program in. We do receive, do have other outside funds through foundations and also through our local health department that allows us to test more people for HIV. All of those individuals are eligible to participate in 340B. As long as we hold the patient chart and we have evidence of ongoing care for these individuals. And these individuals can be uninsured or insured in order to get the benefit from 340B. Our clinic, we set it up to where we utilize the least amount of the medical provider's time. Who's controlling my screen? Go back. Thank you. The least amount of the medical provider's time. So we have two parts, a pre-consultation part that is done with my prevention team. They do it by appointment, they do it by walk-ins, and they also do it out in the community where they do the HIV STD testing, the blood work that the medical provider will need to review later, and also pre-test risk reduction counseling. After the pre-consultation, the medical appointment then happens once monthly on the evenings and also and or on the weekends. Next slide. So I wanted to give everyone an example of how 340B works. Oh, also one more thing, the cost to our patients. We are only for our clinic, because we were strategically targeting people who were uninsured and potentially unemployed. We only charge $35 for our initial clinic visit, and after that there is no fee or additional requirements to any of our patients. And if they come in and say that they do not have employment, we waive the $35 fee completely. We did that to kind of help get a little bit of buy-in, because in my initial research about opening up a PrEP clinic, there seemed to be a need for some buy-in in order for the community and the patients to actually trust that the service is going to be of quality, you know. So next, I wanted to talk about, so how does 340B cost savings work? So just to give you an example, this is with PrEP. The way it works is that, so private insurance, either whether it's private insurance or through Gilead's patient assistance program, they will pay the retail value of the drug. Let's say it's $14.58. Your contract pharmacy, if you choose to use a contract pharmacy, will subtract their administrative fee, and then the 340B reduced cost of the drug, you will pay for that, leaving you with a cost savings of, oops, too fast, a cost savings of around $725. HRSA prefers that we call it cost savings. And if you were to take that and multiply that monthly, let's say you've got 10 clients every month that are accessing services at your clinic, then that is a cost savings of $7,250. If you take that from an annual perspective, that's almost $100,000 that you could potentially be bringing into your organization to use to expand your services and to increase the work that you are doing and or want to do when it comes to PrEP and HIV and STD testing. So it is an excellent tool to help safety net organizations build their foundation and then also expand services. Best practices. Okay, so we've been doing this for a year now. I would say one of the keys for us as we've been building this clinic, since we again are not a clinic, was requesting feedback as we built our clinic. We continuously and continue to ask our clients as they're going through the process, when they're working with our medical provider, how do they feel about the services? What would they like us to do differently? What's working for them? What's not? One example for us that we learned in this process and to kind of help us fix glitches was we serve mainly people who were uninsured with seasonal employment. We didn't know that Gilead's patient assistance program would need copies of their income monthly to approve their prescriptions. This caused some gaps in some of our patients' prescription refills that we weren't expecting, and on the flip side, that we weren't expecting to have to request from them to show monthly proof of their income. So this alone, that piece alone was critical for us to know sooner rather than later so that we could change our processes to make sure that we got all of the paperwork that we needed so that there wouldn't be any delays in the patient assistance program's ability to pay for the drug so that we can continue refilling their prescriptions. Phone apps worked wonderfully for us. My team, because they are used to doing outreach and connecting in the community, utilizing phone apps like Jacked and Grinder helped us to connect with the people. And then once we connected with them, we sooner rather than later got them off of the phone app and would just have phone conversations or communicate with them via email to set up the consultation, to provide the education, and then to set up the clinic visits. That worked really, really well. It also helps though if you have a protocol and a process built in around social media, because one thing I noticed with my team is that everyone talks in these apps and in these phone apps and social media apps in a different way. So the more structure you're able to provide that puts out your agency and not the individual, the easier it is for everyone to pick it up and be able to utilize phone apps in your recruitment and engagement of the community. And lastly, availability. After work hours and weekends definitely supported our patient adherence. And it also helped us to not utilize our medical provider's time. His clinic would close at 5 o'clock. My team would come in after his staff left, and he graciously allowed us to use his clinic space in his team's absence to conduct our clinic. Minus his nurse practitioner who stayed with us to provide the actual clinic services. Lessons learned. So a few things that I just want to share with y'all that I wish I knew before I would have started. We as a social service organization, since we most of our money and funding, even our fundraising activities, goes to support our housing programs for our clients who are living with HIV. We had zero startup dollars to build this program. We started with about a quarter of one of our internal existing staff. And then we built as we were engaging in adding new patients to our PrEP clinic, PrEP clinic. But had I had startup dollars, I would have, and I would definitely recommend for you to invest in an electronic medical record or electronic health record before you start, because it's one challenge that has been for us is transitioning not just my team, but also your medical provider from paper to electronic files. It takes more time, and often there is resistance because you've already started in one way. Also, if you have startup dollars, invest in a medical assistant or licensed vocational nurse. They don't have to be full-time, because I understand that can be costly, but even on a part-time basis, someone who has experience managing the clinic process is definitely helpful. Marketing and development is also useful. These are two examples of two marketing campaigns that we had going on prior to the startup of this clinic and throughout the clinic. It just helps to get the word out. It takes the populations that we were reaching out to, once again, off of the phone apps onto our website, so they can watch a video, learn some things, and then reach out to my staff to have additional conversations. And lastly, Uber Health or Hitch Health, having transportation readily and easily available so that those who need it can get it, so that there's no delay. We were only using 2.5 hours a month of a medical provider's time once a month. So it was really important for us to make sure that all of our clients that needed to see the medical provider that month was able to get there. So transportation is definitely huge. And lastly, if you could, within your area, if you could shadow an existing PrEP provider. We initially, when we started, we made some errors in our clinic flow, and it would have been helpful for my team and my staff, because they literally went from testing out on the streets under the freeway to being in a clinic setting. That is very different if you don't have that experience. And it's just simple things that can just be avoided if you shadow an existing PrEP provider, like how to complete the Gilead application, the proper way to stack patients in a schedule to avoid downtime of your medical provider and staff. All of those things were very, very useful. And that is it. I see a lot of questions, but I'm assuming you're gonna want me to answer later.
Hey, yes, I'm sorry. Yeah, we're gonna, there's a lot of questions coming in. Thank you all so much for your questions. We'll definitely address the questions at the end of the webinar. Thank you again, Nikkei, for sharing that information. It definitely sparked, some conversation in the chat box. So I'm looking forward to the Q&A segment later on. So our next presenter is Damon L. Jacobs. Damon L. Jacobs is a New York-based licensed marriage and family therapist and HIV prevention specialist who focuses his work on health, love, and pleasure. He is best known for championing the use of HIV pre-exposure prophylaxis, PrEP, through his work on social media, newsprint, broadcast appearances, is featured as one of 35 leading HIV activists by the Advocate magazine, one of the top 10 influential voices in HIV/AIDS for 2016 by Healthline magazine, part of the HIV Hero series through Metro's First magazine, and one of the 10 most captivating voices of 2014 by HIV Equal. He was honored to receive a Commissioner's Special Recognition Award through the New York State Department of Health in 2016. Now, unfortunately, Damon was not able to be with us at this time, but he did record his segment for everyone earlier. If you have any questions specifically for Damon, please indicate it in the Q&A section or in the chat box, and I'll be sure to forward the questions to him and then get you the answer to your questions. So what I'm going to do now is I'm going to just go ahead and start his presentation. Sorry, everyone, it seems like you weren't able to hear. Give me 1 second, let me see if I can fix that for you. Okay, hopefully you guys can hear now.
Innovative solutions for hard-to-reach communities. And I just want to begin by giving a shout out to my colleague Valerie Rochester Morgan, who pointed out to me recently that a different way to see this would be innovative solutions for hardly reached communities, and to think about how we're reaching out to communities that may not ordinarily get reached out to. My own background in this goes back to 1991. And back then was really during some of the worst days of the AIDS crisis, and knowing people with AIDS and working with people with AIDS and loving people with AIDS, that we lost people to AIDS. And at that time, the only option that we had to help people stay HIV negative if they were sexually active was to use condoms only. And this was often the message we had on street corners and bars: condoms only, condoms only, condoms only. That's the only option people had if they were going to be sexually active, and not always certain of the status of their partners. However, as you can see from the CDC slide, despite all of our efforts to have people wear condoms 100% of the time in every sexual encounter, we can see that the new infection rates in the US really leveled off around the mid-1990s. They leveled off at about 50,000, and they didn't really go up or down for the next 20 years. And so clearly there was a different strategy that needed to be used. It was around the end of 2010 that I was working with a Project Achieve in New York City doing outreach for vaccine trials, that I learned of this breakthrough. We were all gathered to the office to learn about this breaking news at the end of 2010, that this new study about IPREX was showing that people who used Truvada had significantly less likelihood of acquiring HIV, even up to 99% less when they took the pill daily. For my own personal reasons, I opted to start using that myself and decided to start talking about that and helping people learn about their options. I naively thought that that was going to be something that would bring joy to people, that people would be happy to hear about PrEP, that this would be something that might enhance their pleasure and their quality of life. Instead, I got this. I got to be on the Huffington Post at the end of 2012, and as a response, one of their writers wrote this column about me, or about anyone really, that was going to be using Truvada as PrEP in order to stay HIV negative. And then following the FDA approval on July 16th, backlash began, and in some media sources, in some service agencies, and definitely amongst a lot of online bloggers, PrEP and Truvada kind of became a dirty word associated with being a quote whore, or some other name that was intended to promote stigma and shame about celebrating one's sexuality. I use this for myself as a way of thinking, okay, This is kind of weird because now we have a way to reduce HIV infections by about 99%, and not only are people not learning about it, but those that are learning about it are responding to it badly. I started to think about ways that I could get this message out to groups of people that really needed to hear it, that really wanted to hear it. And because I already kind of had a Facebook addiction, I decided to go to Facebook and start a group where people could learn the science, the data, the facts, the information about PrEP, ask questions, have them answered by people who knew the science, by some of the researchers and doctors that had worked on the study, and really try to build a community that was built on respect for difference as well as respect for empirical evidence. Much to my surprise, this group that I started on July 1st, 2013, began to take off and actually was well received, and first got noticed in the New York Times towards the end of 2013. That's me trying to look up in the New York Times. I don't think I look so tough, but they don't let you smile when you do these things. But the media really began to take interest and began to report more accurately about PrEP toward the end of 2013. And around that time, as you may recall, the ACA started becoming available in 2014. The CDC started adopting guidelines. The World Health Organization started adopting guidelines. And there started to be a trajectory of communication and information that was more accurate and available to people who had the privilege of seeing about it or hearing it. Still not being covered in mainstream media, but at least it was out there more often. On September 30th, 2015, the Facebook group that I created was mentioned and adopted in the World Health Organization and PrEP guidelines as helpful for peer-to-peer sharing of experience and solutions. And the reason I thought this was kind of amazing and significant is that the first time I saw a major medical governmental agency acknowledge the role of social media in getting the word out to people, that because it was not being widely spread by the traditional echelons of agencies, organizations, corporations, conglomerations, the traditional service routes were not doing their job at helping people learn about PrEP, that it was really coming through to people in social media and the conversations in social media that were helping people adopt this and get the word out. Following that model around the same time, Bruce Richmond started using Facebook and other social media sources to help consumers learn the message behind undetectable equals untransmittable. The message that if someone is undetectable and virally suppressed for 6 months or longer, they cannot transmit HIV to others. And he began a very successful media campaign called the U campaign. And again, really thinking about how we get this message to consumers. It felt like, in the 90s, you needed a newspaper or an agency or a billboard or some way to get the message out. But thanks to social media and the digital resources out there, you really don't need a lot of money, and you don't need those resources. You just need a computer and a large cup of coffee. And to be honest with you, I probably don't even really need the coffee. So a lot of lessons have been learned in this time. So based on this experience and really this interesting journey with PrEP and then with U equals U, I come to understand some information and some facts that I didn't really know before this. How social media really does have the capacity to be a source of compassion and to provide community in order to provide empirically driven education. And that people are more often open to this kind of information and willing to hear this information when it's delivered peer-to-peer in a supportive environment through social media. I know we've all heard a lot the last few years about the dangerous aspects of social media, and believe me, I'm not naive to that at all. But I've also seen the other side to this, and I have seen how Facebook and other platforms can really be a source of meaning and education and compassion in terms of creating community, helping people make healthier choices. Because we're in the digital age and because we have social media and you have loudmouths like me and Bruce, it is more important than ever for healthcare providers to be truthful and fact-based in their messaging. I can't tell you how many times people come into the group and say that my doctor told me something that wasn't true. My doctor said that PrEP was only 82% effective. My doctor said that my kidneys are going to rot if I take it for too long, so I have to take breaks. Doctors are still telling their clients these things, and we will use Facebook to give them the facts, show them IPREX, show them all the data, often disproves what the doctor says, which further eradicates the trust that the doctor or provider may have had. It is so important to be transparent now more than ever in terms of delivering this information. Failing to give consumers the facts or misleading information will erode the trust. And I think that's a shame, because we really want to think about this opportunity now to rebuild or build trust in communities that have been disgruntled and traumatized by healthcare communities in the past. I've also learned that consumers are more likely to take action when their sexuality is celebrated, affirmed, and normalized, when someone is not being stigmatized for being sexually active and possibly even having an STI at some point. If that's normalized and affirmed, and then people will make healthier decisions about preventing HIV and treating STIs. And finally, it is more important than ever that providers build relationships based on respect, facts, collaboration when offering services to disenfranchised communities. Once again, shame, finger pointing, shoulding, and telling people that they're sinners or pathological because they like to have sex with a lot of different people is not going to help us end the HIV epidemic. But meeting people where they're at, listening to them, building trust, and helping them make healthcare decisions is the way that we can see this HIV epidemic change and utilize PrEP and U equals U to help people have healthier and happier relationships and quality of life. Next slide, please. So I want to thank everybody for listening to this. I hope you'll all join the Facebook group, PrEP Facts Rethinking HIV Prevention and Sex. And together we can end this epidemic with intelligence, with compassion, with honor for each other, and with love. Thank you.
All right.
Again, everyone, please note that Damon was unable to participate with us right now, so he recorded his portion earlier this morning. So if you do have any questions, please feel free to add them to the Q&A box or in the chat box, and I will get the questions to him and I will share the answers with you. All right, so now on to our next presenter. Oh, no, let's start. Okay, there we go. Our next presenter, Angela Hoff. Angela Hoff is currently the project director and clinical provider for TelePrEP, a public health partnered virtual pharmacist service providing HIV pre-exposure prophylaxis to the people of Iowa. TelePrEP works to overcome barriers to PrEP existing in a rural state. Stigma, privacy issues, long distances to PrEP providers, and primary care provider shortages, especially in the rural area. All right, Angela, I'm going to hand over the controls to you, and you can feel free to take it over when you're ready.
Okay, great. Can you hear me okay?
Yep, I hear you.
Great. Well, thank you so much for having me today. My name is Angie Hoth, and I am here representing the entire TelePrEP team. We take turns talking about our program and are very excited about it. Iowa TelePrEP was created out of a need identified by our medical director and public health professionals to improve PrEP awareness and accessibility in Iowa, especially for people in rural areas of the state. It was not uncommon at all to hear stories similar to this gentleman, a 42-year-old man who has sex with men but didn't identify as gay or bisexual and was in a primary relationship with a woman. Sex with men occurred infrequently and sometimes condoms were used. He lives in a small town. He generally travels 75 plus miles one way to obtain HIV screening from a provider in a larger city for fear of disclosure to a provider within his community. On one of these visits, he had a negative HIV test and requested PrEP, but he was told that it was not offered in the clinic. 6 months later, he presented to the UIHC, University of Iowa Hospitals and Clinics Virology Clinic, with a new diagnosis of HIV infection discovered on routine testing in association with a life insurance application. And unfortunately, this is not the only story like this within our state. Iowa is a rural state with a total population of around 3 million, so our urban areas are not like most urban areas. And with 35 to 40% of the population being rural and about 1/3 of new HIV diagnoses occurring in people who live in rural states or live in rural counties. By definition, rural populations are small and dispersed. Rural USA is comprised of 97% of the land area of the United States and approximately 18% of the population, and accounts for 6% of new HIV diagnoses. And even though rural areas account for a small proportion of new HIV diagnoses, rural and small urban populations do matter. Annual HIV incidence in rural areas of the contiguous upper Midwest states approximates HIV incidence of one large Midwestern city. In rural settings, barriers to PrEP exist at all steps of the PrEP continuum. Barriers identified in Iowa include geographic isolation and long distances to PrEP providers. When you add in poor weather conditions, the isolation is even greater. Stigma is a problem in rural settings, and privacy is a real concern. There is a fear of disclosure, especially among people living in small towns. People are afraid to be seen walking into a place that does HIV testing. Many people's relatives work in the healthcare or public health system in a rural county, and many people have a primary care provider who is also a family friend or potentially a relative. There's a shortage of primary care providers in rural Iowa counties, and established primary care providers are overburdened by current workloads and wary of taking on additional patients and work. And so all of these barriers have made it very difficult for people in Iowa to obtain PrEP. Once the barriers to PrEP were identified, we started designing the PrEP service. Partnerships were formed between the Iowa Department of Public Health, the University of Iowa Healthcare System, and members of the community. We looked closely at programs and services already in place, talked to stakeholders from public health, medicine, pharmacy, and health services, talked to people in the community, and talked to people who were already taking PrEP and those interested in PrEP who would actually use the service. The TelePrEP prototype was designed taking into account information from the interviews and piecing together existing resources. Rapid prototyping of the service occurred in conjunction with the local county public health department, and changes were made as needed to streamline services. From this initial work, the Iowa TelePrEP model was born and tweaked. Iowa TelePrEP is a public health partnered virtual pharmacist telemedical PrEP delivery service, which we shorten to TelePrEP. It's public health partnered in that it utilizes existing public health HIV and STI testing sites and partner services infrastructure to provide PrEP education and identify people who may benefit from PrEP. It's virtual in that everything is done by internet and phone, and the providers are pharmacy specialists working under a collaborative practice agreement with University of Iowa infectious disease physicians. And it uses a HIPAA-compliant telehealth platform for its visits. Clients can engage with TelePrEP by 3 different mechanisms. First is they can be seen by public health and referred by public health to the TelePrEP program. They can self-refer through the TelePrEP website, or they can call, email, whatever is most comfortable for them. And people who are working in our HIV virology clinic can refer partners of people living with HIV to the TelePrEP service as well. Clients talk with the PrEP navigator, who educates them about PrEP, the service, and assists with insurance navigation and medication assistance programs. And then clients meet with the TelePrEP pharmacist, who conducts a medical, sexual, and medication history and provides education about the PrEP medication and risk reduction. The clinical pharmacist orders the lab test, discusses the results, and prescribes the medication under the collaborative practice agreement. Labs are obtained locally at a site of the client's choice, and medication can be mailed. So we set up the service to overcome some of these barriers that we identified. In-home video visits, address stigma and privacy concerns and eliminate the geographic barriers to PrEP and monitoring. Use of local labs of the client's choice, again, overcomes geographic and privacy barriers. We mail the medication in plain packaging to an address of choice, and the use of a clinical pharmacist collaborative practice works in response to the provider shortage that we see, especially in rural counties. During the prototyping process, we discovered that only about half of our clients were able to get extragenital testing for chlamydia and gonorrhea. So we really wanted to increase our screening for STIs. And so we had heard about a home test kit that was used by Emory University. So we reached out to them, and we are currently partnering with Emory to pilot test use of their home PrEP testing kit by TelePrEP clients. And so the kit is really slick. The instructions are very easy to follow. The patient takes their own blood sample using a lancet and drops the blood into the vial. They do their own self-swabs, rectal and pharyngeal, and then provide their own urine sample. This is packaged up and sent back overnight by FedEx. And if it's acceptable to people that we're pilot testing it with, what we are going to do is work with our state hygienic lab to develop something similar in order to improve adherence to the monitoring of PrEP. So in conclusion, we've learned that rural PrEP delivery models must identify individuals at risk for HIV and increase PrEP awareness, especially in rural areas, efficiently scale up and geographically to serve large numbers of vulnerable individuals in a dispersed population, and overcome barriers related to stigma and distance. And in addition, innovation does not necessarily require new technology. What we did is we just took what was already available, pieced it together, and played around until we came up with something that seemed to work, and then tweaked it as we went along. Pharmacist collaborative practice has been great to overcome PrEP barriers related to rural provider shortages, and public health partnerships that we have established ensure linkage to treatment for syphilis, gonorrhea, and chlamydia, as we're not able to provide treatment for syphilis and gonorrhea by telemedicine. And so our theme from the beginning is start where you are, use what you have, and do what you can. And that is all I have for today, and that is my contact information if you would like to reach out.
Awesome. Thank you so much. Angela, can you hear me now? Hello, hello, hello.
Hi.
Oh, you hear me? Okay.
Yeah.
All right. So now we're going to go straight to our question and answer section. But before we do that, I do want to thank you again, Angela, for providing information on TelePrEP. I think your TelePrEP program is quite innovative, and I'm sure a lot of people are going to have a lot of questions behind it. So as we're going in, I'm going to go ahead and open up the Q&A box. See what's the first question we have. All right, I believe this question is for Nikkei. In your use of apps, Jacked, Grindr, etc., to communicate with clients, how do you ensure adherence to HIPAA rules and regulations?
Great question, and definitely something we made sure we had in place before we started. So as I mentioned, we tried to make sure as quickly as possible, once we made the introduction in Jacked or Grindr, and so for those of you who've been in those systems, you know it's about the individual. So we're not, we can't post ads or anything like that. We use our staff person's picture, their name, it is who they are, and they state within the system when they log in, hey, this is so-and-so from AIDS Foundation Houston. I'm here and available if anyone wants to talk about PrEP or is interested in getting on PrEP. And of course, it's not in that language, it's in their young adult language, or, you know, the population's language. And then once someone responds and say, hey, yeah, let me talk to you. Can I, you know, can we talk? My staff person then immediately provides them with their phone number, the agency email, and then also shares our websites. And then they also get from that person, if they're willing to give it, their phone number as well. So we don't have any confidential conversations within those apps.
Awesome. Thank you. Hopefully that answers your question. I have another question, and I believe this question would be fitting for both Angela and you, Nikay. Were you guys on PEP?
Yes. So luckily, since we are using a private medical provider, this particular provider has done a wonderful job of definitely providing the PrEP prescription, but also making sure that PEP was available for anyone who needed it. The provider, the nurse practitioner, Maggie White, she would do full patient exam, and if we do have a few women that are within our clinic, I believe one was provided with birth control. We did STD treatment, all of those things we are able to cover. Not everything is 340B reimbursable, but for those things that were, we did get the reimbursement.
Awesome, thank you. And Angela, do you have any comments as far as where you guys are on PEP?
Yeah, we have discussed it. We are not currently providing PEP, but we are talking with small town ERs and how we can sort of partner with them in order to work out doing any sort of physical exam that needs to be done, and then doing history and medication provision by telemedicine. So we're really in the works and probably a good 6 to 12 months away from being able to provide PEP.
Awesome, thank you so much. All right, so for our next question, I believe this is again to you, Nikay. When you use Uber, do you provide car service both to and from the medical appointment?
Yes, we are providing it to and from the medical appointment. My staff don't offer it up initially, but when they give that second or third reminder call or text to the patient about their clinic visit, if the patient says, I'm stuck, I'm at school, my mom has my car, whatever the issue is, we do provide it both ways.
Awesome, thank you. And now another question that I guess is good for both of you, Nikay and Angela. Can you speak to helping adolescents access PrEP, and how do you handle parent consent?
I'll start with that and saying, so our target population is all adults. We do not, even though it is now FDA approved for adolescents, we are not targeting adolescents. Houston has several other clinics that are actually youth friendly. So when a youth, anyone under 18 reaches out to us, we connect them with those clinics, Baylor Teen Clinic, and a few others. That should be a whole nother UCHAPS session probably, Kenya.
It is.
Yeah, and in Iowa, so far in our service, our youngest client has been 18. We've had a few adolescents pop up as potential. In the state of Iowa, we're pretty fortunate. We're in order to obtain an HIV test, we need written permission from the adolescent. They do not need to have parental consent. However, if the test is positive, then the parents are brought into the conversation. If it's negative, we can actually talk with the adolescent and work with them around PrEP, and can provide PrEP without parental consent. Where that gets really tricky, though, is how to pay for the medication, because the majority of adolescents are on their parents' insurance, and that has actually been a barrier to starting PrEP in some adolescents, is that they don't want to use their parents' insurance, yet they don't really have access to any other way to get the medication.
Thank you for that. We have another question. Is there a confidentiality issue when using TelePrEP?
For the video visits, we use a HIPAA compliant platform for the actual visits. We also get patients' communication preferences, so we have them tell us if, when we are communicating with you, what is your preferred method? Do you want to use texting? Do you want to use phone? Do you want to use encrypted email or regular email? We never initiate conversations that are confidential from our end, but if they ask a question and they're comfortable using texting, what we will do is say, hey, can I call you on the telephone and talk about this? So from a visit standpoint, we are HIPAA compliant, and then it's primarily telephone conversations, and then we have limits around sort of what we'll discuss using text and email.
Awesome, thank you. So now I'm going to open the floor for any additional questions. Any additional questions? Feel free to type them in the question and answer box or in the chat box. All right. Doesn't seem like we have any questions popping up. Okay, if a question does arise sometime later, you've thought about this, you digested this webinar a little bit, or you watched it again later, feel free to shoot me an email and I will field your question out to one of our presenters to get an answer for you. You can take a look at some of our other resources that we have in the UCHAPS Resource Center. There was a Women in PrEP webinar that was done previously, as well as a 340B What You Need to Know webinar that was done that can provide some additional information to what was provided here earlier. I got a question for contact information for the speakers. I'll be sure to send that out with a follow-up email, our speakers' email addresses, so you can ask some questions as well if you'd like. And at the end of this webinar, which is now, there's going to be a few, like a 30-second, I know this is a few minutes and then it says 30 seconds, that was a typo. But please take a few seconds to complete the 30-second survey. That's going to appear once I close this out. If you don't receive the survey, please email me at kenya@uchaps.org. The survey is very easy, very quick. It'll help us to have better, more impactful webinars in the future. Again, thank you, everyone. Thank you to our panelists. Thank you for everyone for joining us this afternoon. Have a great day. Thanks. Bye-bye.